All right. So let's review a couple things that we learned last week. Not last week, on Monday. I'm all over the place today. And let's discuss our integumentary system. Essentially the skin, and we learned about the layers and several of the components there, but now we're going to just discuss it in a little bit more detail. So again, the skin, the integument, is one of the four membranes of our body, right? And that's going to be the cutaneous membrane there. And so it plays a huge role in protection for us. Why? Because it forms a barrier. So we have some sensitive tissues that are found underneath our skin and inside of our skin. And so we want to protect those. So the skin forms a pretty effective barrier, giving us what we call innate immunity. And innate immunity does not discriminate against certain types of pathogens. You know, it's not like it's going to stop viruses from entering the body, but not bacteria, right? Doesn't discriminate. It's just going to do its job. Like these walls here, right, are going to keep sound in the room and possibly light. The skin is going to keep pretty much most pathogens out of our body here. So as we go through this chapter, we're going to be focusing mainly on the layers of the skin, but we're also going to talk about some of the accessory tissues, which we didn't talk about in lab, like nails, for example, and hair. Not really thrilling things to discuss, but maybe for some of you, you might find it interesting. But we're going to discuss some of those hopefully today in class. So as you recall, I told you, I find the integument to be a very helpful tool when I'm trying to assess an individual's overall health. We all do it, right? When we're looking at folks, right? When you are maybe having a face-to-face conversation with them, you might notice some peculiarities with them. You might notice, all right, that they have a yellowing of their skin, or they might have increased hue or redness, or actually an absence of color, maybe in their lips, right? So there's a lot of different things that you can use the skin to help assess, right, overall health of an individual. It is the body's largest organ. Again, I won't ask you to give me specifics on areas of thickness of the skin, but keep in mind, we discussed this before, where you have thick skin and where you have thin skin. Right? Where do we find our thick skin? Soles of the feet, palms of the hand. Yep. And then where's the thin skin? Everywhere else. Top of your head, back of your head, on your forearm, the back of your hands. All right. So keep that in mind. So know where the thick skin is, and then you'll know definitely where the thin skin is. All right. So let's talk about the different tissue types that are in the skin. Again, more review. All four tissue types are in the body. So to review, epithelial tissue, connective tissue, muscle tissue, and nervous tissue are our four tissue types. I have made it a goal of mine that anybody that takes this class, when you come out of this class, you at least know most of the material, but you'll know at least those four things. Right. So epithelial tissue is primarily what the epidermis is made up of, that outer layer, stratified squamous epithelium. We'll have some other cell types in there. Then we go to the deeper layer of the skin, that's the dermis. And so that's pretty much where the remainder tissues are going to be. You'll have connective tissue in there, areolar connective tissue, dense irregular connective tissue. You're going to have glands, right, which is epithelial tissue. You're going to have hair and hair follicles, and what attaches onto that hair follicle? Smooth muscle. Gives you those goosebumps. And then you're going to have tons of nervous tissue in there. Lots of receptors and neurons, all right, that are going to attach those receptors for sensory input information from the external and internal environment. How cold it is in this room. Or if you are touching something and pressing against it, right, that pressure is going to stimulate some of those receptors. So all four tissue types are going to be present here, right, in your skin. And so as we move through this course, you're going to see we're going to be discussing other organs and other systems in which we'll see all the tissue types, right, and present in a lot of those areas there. All right, so let's start off talking about some of the functions here. And like I said, we discussed it briefly in lab, but now we're going to go into a little bit more detail here. So you notice the first one here that I put up there is protection. And I mentioned that the skin acts as a barrier, right, to the world. Right? Keeps a lot of bad stuff out, keeps the good stuff in, hopefully. And so it is going to protect us, obviously, from injury, trauma, right? And so that role in itself is a pretty large role. So the skin does a wonderful job in doing so, because if you look at all of these possible pathogens that could affect you, the skin is quite effective in keeping a barrier. And we discussed the role of the melanocytes in lab, and we learned that your skin is going to help protect you against ultraviolet radiation. And the sun gives off two types of ultraviolet radiation. Well, three, I should say, that we know of. All right, ultraviolet radiation, and it comes A, B, and C. C doesn't make it to the earth, all right, but A and B do. And they're both bad, but how I learned it was B was the worst, all right? So easy to remember, B bad. And so what your cells do, the melanocytes, are going to make melanin, which is going to coat the nucleus. So that protects your DNA. So you can see a huge role there, right? Because solar radiation can play a large role in what? Skin cancer, yeah. Skin cancer is by far the most common type of cancer that affects the human body, right? Prostate cancer is #1 in males. Breast cancer is #1 in females. Skin cancer is 5 times more than breast cancer in women and prostate cancer in men. So you can see how important that our skin, our integument, plays a role in protection for us there. All right, prevention of water loss, dehydration. All right, so a good portion of your body, majority of your body, is made up of water. So keep in mind, it's noted up here, your skin helps to prevent against unnecessary water loss. There's necessary water loss, right? So like when you're sweating, that's necessary water loss. When you're urinating, that's necessary water loss, all right? But the skin prevents us from losing the unnecessary water loss. And so glands play a big role in that, and we'll talk about this here, all right, in a second, this process of transpiration. I made mention of that, right? Transpiration is when your glands, your sweat glands, for example, will just release a small amounts. I describe it as a puff, right? You don't know this, but they will release, all right, intermittently, all right, mild amounts of water, or excuse me, of sweats. You won't even notice it, okay? So we don't technically consider it to be sweating. But again, it's one of the ways that we can lose water from our body here. But this is an important concept that I tell everybody. Your skin is water resistant, but not waterproof, as evidenced when you sit in the bathtub for an hour. What happens to your skin when you get in the, yeah, it gets pruny. You get wrinkles in it, all right? And that's because, all right, you have absorbed some water there. So keep that in mind. Water resistant, not waterproof. And so that plays a big role here when we're talking about prevention of water loss. Dehydration, that's one of the things that's the #1, if any of you have worked in a burn ward or in medicine in regards to burns, is there's 2 things that medical staff are significantly worried about for burn victims. One is up there on the board, dehydration. What do you think the other one is? You nailed it. Infection. Okay, so those are the 2 big ones that they are concerned about. Dehydration, because you damage significantly that organ, the skin there, and then infection. So keep that in mind here. All right. Our next function is metabolic regulation, specifically with vitamin D. So vitamin D, yes, we call it vitamin D, and there's a lot out there when we discuss how you want to classify vitamin D. I'm not going to talk about it here, but in some realms, it's referred to as a pro-hormone, because eventually the active form of vitamin D is called calcitriol, and that is a hormone. More on hormones when you get into chapter 17, but here's the cool thing about our skin. Our keratinocytes, when they are exposed to sunlight, to ultraviolet radiation, start to form and make vitamin D. The inactive form, which is known as cholecalciferol. This is inactive, right? Vitamin D3 or cholecalciferol. So your skin makes it, or excuse me, your keratinocytes make it, and then they dump it into your bloodstream. And so it starts to circulate all throughout your body. And so it's going to make a couple stops. Right? One of the stops that it's going to make is the liver. And so the liver then is going to then convert your cholecalciferol, I don't have it up here on the board, on the screen, into what we call calcidiol. All right, so calcidiol is this intermediate precursor to the active form of vitamin D. So the liver is helping with the process, so it's made calcidiol, so it dumps the calcidiol back into your bloodstream, and that circulates around. And then it winds up going to the kidney where it is converted into calcitriol. So you want to know, when we discuss the metabolism of vitamin D, where it's made, which is where?
Liver. No.
Cholecalciferol, what makes it burst? The keratinocytes, skin. Skin makes the cholecalciferol, that's the first form of vitamin D, and then it gets put into the blood, goes then to the liver, gets converted into calcidiol, and that goes back into the blood, makes it to the kidney, which is then converting it into calcitriol. That's the active form. So this is an important hormone, calcitriol, because it helps with the absorption of calcium and phosphate in the small intestine. And it's going to work with another hormone, which we'll learn in chapter 7, called PTH, parathyroid hormone. And then, right, because it's going to help absorb calcium and phosphate, what's important about calcium? What do we need that for? Bones, that's right. We've learned that so far. But we're going to see that we need calcium for muscle contractions and for our nerves to function correctly. So it's very important metabolite. Very, very important. So that's why vitamin D doing its thing is very helpful for us. Phosphate. What do we need phosphate for? Well, what was the first thing that you told me about calcium? What do we need calcium for? The first thing. Bone. You need phosphate to do that too. Right? But, also nailed it. Someone said it. ATP. ATP. So we need phosphate for ATP, and we're going to learn about some of that later on. So I guess we could say then that vitamin D is important in regulating blood levels of calcium and phosphate. So if blood levels of calcium and phosphate are low, vitamin D is going to help increase that because it helps to increase the absorption of phosphate and calcium from your small intestine. And we'll learn about some other things that it does here. More on that when we get into chapter 7. All right, when we're talking about, all right, continuing on with metabolic regulation here, we're going to see one of the other functions for that metabolic regulation are our melanocytes. They make that melanin, that delicious, wonderful melanin that is going to help, all right, convert, or not convert, but cover and coat sensitive structures in the cells, but also at the same time, it will affect the color of our skin, okay? Usually giving us a darker skin tone there. So the skin does quite a few activities when it's involved in metabolism. We'll see that when you're taking certain drugs. If you take a transdermal patch and put it on, you will have enzymes in your skin that help to convert, in most cases, an inactive substrate into an active product. And so the skin plays a large role in that. All right, secretion and absorption. All right, when we're talking about secretion, we will think sweating. So then you got to start to think, well, what's in our sweat? Well, it depends on which glands, because last class we discussed the 3 different types of glands. We talked about the merocrine glands, the apocrine glands, and the holocrine glands. And so depending on which gland we're talking about, will determine what's going to be found in our sweat. So, for example, our American glands, basically our sweat glands, the majority of what those glands are going to be secreting out in your sweat is water. But at the same time, not so much, not so much for women, but I see it more with men. Men usually have a tendency to hold on to things. We don't want to throw away one of our shirts, like for whatever reason. I don't know why, right? Some of you might know, you might be married to somebody that does not want to throw away a shirt. And then you're doing the laundry or folding the laundry. I'm not saying that's what the significant other does, all right? I do my own laundry. I don't trust anybody to do my laundry, all right? But you might notice in an older white shirt, pit stains, all right? With a yellow coloration. That comes from the sweat, specifically from those metabolites, but mainly from urea. It's dilated urine. That's essentially what urea is. I mean, I'm exaggerating a little bit, all right, but it has a nitrogen compound in there. So that's what you're going to see in your sweat. We're going to get rid of mostly water, but also urea, which is a cell waste, salts. I'm sure we've all tasted our own sweat. You might have been working out and sweat drips into your mouth, and it's salty, sodium chloride, right? We're getting rid of electrolytes that way, right? So it plays a nice role in our electrolyte homeostasis. If we have too much electrolytes, we can get rid of it in our sweat, in our urine, right? Sebaceous glands, they play a great role in helping to keep our hair lubricated. So sebaceous glands secrete what's called sebum, and it's an oily, viscous material, and it coats our hair on our head, hair on other parts of our body. And so some of us produce more sebum than others. And so you might see, I've got a family member in my family that when they take a shower, they only wash their hair once a week. So you can tell when it's close to that washing time because their hair is more oily. That's because they have all that sebum that's on their hair. Right, so keep that in mind. All right, then we've got absorption. So that was secretion. Now we're looking at absorption. Right, you heard me mention about the transdermal patch, like the Nicoderm or whatever they call the cessation medication for smoking nowadays. But because it's your largest organ, you have a large surface area there. So it's a great way to administer drugs because of that large surface area. You have a large area for absorption. So we can use it, right, for various chemical and drug absorption. And the nice thing about it is our skin is selectively permeable. It'll only let certain things in, all right, which is good. That's the way we want it. So it's a great way, all right, for transdermal administration for certain medications that folks will need. I had a dog many years ago, almost 2 decades ago, and he was a puppy, and he was a small Yorkshire Terrier Poodle mix, and he got out of the backyard, ran out on the road, and got hit by a car. But the good news is it's a happy ending. All right. The good news is the dog didn't die. The bad news was that his bottom 3 lumbar vertebrae in his spine were fractured, were broken, and he was paralyzed. He wasn't, I don't think he was even 9 months old. Long story short, took him to the hospital. They said we have to operate. They operated on him, and they put 8 steel rods or titanium rods right into his spine. It was an amazing surgery, fixed the back, but it's a painful procedure. Guess what they gave him? Painkiller. But what's the one that you hear in the news all the time that's been killing people? Fentanyl. Yeah, they gave him a fentanyl patch. Fentanyl's powerful. It's a synthetic painkiller based off of opioids, but they put that on him. He was feeling no pain. All right, no pain whatsoever. But they had to shave his back and put it on because it was able to be administered kind of like a slow release, how it was designed. And it was perfect because you just put the patch on and he was good to go. Right. So the reason why is, remember when we went over in the lab, we learned about the anatomy of the dermis. Remember all those blood vessels that you got to see, and all those blood vessels in the subcutaneous layer in the hypodermis? Right. That's why. It's a great way to administer drugs because of that absorption process there. And that's essentially what happened with My dog. Nice slow absorption over the period of 3 to 5 days, right, and I didn't even have to do anything. Just make sure the patch didn't fall off of them. So it's a great way, all right, for absorption is one of our functions there. Immune function, right? Our skin, besides the fact that it's a barrier to the outside world, remember we talked about in lab on Monday, in the stratum spinosum, okay, that's that second deep layer of the epidermis, the stratum spinosum, we had those dendritic cells, or those cells of Langerhans. And these are the cells that I told you that are constantly monitoring their neighboring cells and inspecting them and making sure that they're healthy and normal. Because if they start to become unhealthy or abnormal, right, i.e. cancerous, then these Langerhans cells wipe them out. So they'll literally go after those cancer cells and take them down. Now, if you cut yourself and maybe some pathogens like some bacteria have kind of crept in there, same thing. Langerhans cells will start to attack those pathogens as long as they come in contact with them. So our skin plays a wonderful role in immune function, mainly through that innate immunity that I was telling you about, the fact that it's physical barrier presence there, but we do have immune cells in the skin, both in the epidermis and the dermis, that help with that sort of immunity also. Ooh, temperature regulation. This is back to chapter 1. When we were discussing thermal regulation and negative and positive feedback loops. Right? So we saw the person chopping wood and sweating profusely and what the body was trying to do. Well, that's what we're going to see here with temperature regulation. So we're going to be dealing with capillaries and sweat glands. What are capillaries? Blood vessels. They're the smallest kind of blood vessel. And so what we're going to see here with temperature regulation is, right, when we all know what happens when we get too hot, we start to sweat. And the blood flow to the surface of your skin increases. Your blood is 1 degree warmer than your body temperature. And so if we bring blood to the surface of your skin, we can release the heat much more effectively. Now, couple that with sweat evaporation, we can increase more effectively that release of heat, thereby decreasing our body temperature. Vice versa, when you're too cold, you start to shiver, that's muscles, but at the same time, your blood flow to that area decreases, diminishes, because we're taking that warm blood, right, and we're going to pack it around our internal organs, the vital organs, because they need it. Right? And so we shunt it away from the surface of our skin. So this is an important concept here that I want to talk to you about: blood vessel dilation and blood vessel constriction. So normally, your blood vessels are what we call in a partially constricted state. And what that means is they've shrunk down a little bit. They just got a little, the lumen, the diameter of the blood vessel. All right, so you see, here's your blood vessel. Okay, it's a big old tube. And then what we're going to do is we're going to cut it right through that way, so we're looking at it on end. So that's a blood vessel in a normal, like everybody here, as you're sitting here, not doing anything really other than listening to what I'm saying and taking notes, right? So you're not being too active. So we're not really going to influence your blood flow other than keeping you alive, all right? So in that state, your blood vessels are mostly in what we call a partially constricted state. So they're just kind of shrunken down a little bit. When you start to work out, or we'll say with temperature regulation, when you get, all right, what's the first example? All right, dilation. So when you get hot, your blood vessels will get bigger. The diameter will get bigger. So what does that mean? If we go from your blood vessel being like this, to going to something like that, what do you think is going on with blood? Nailed it. You're getting more blood flow. Would you all agree? It's like a hose. Okay, bigger hose, you can get more water flowing through. Same with pipes, right? So decent amount of blood here, but you can get even more blood here. So you're going to get, so this occurs, right? This is called vasodilatation. dilation is when the diameter of your blood vessel, right, gets bigger. So that vasodilation allows for more blood. If we have more blood flowing in that area, we can release more heat. So that's what we're going to see when our bodies get too warm. Now, if we go the opposite direction, now our blood vessels get small. They shrink down. So they go from here, now they get small. Is it easier for blood to go through the blood vessel when it's like this or when it's like this? Right, when it's bigger. So now we've gotten to the point where the blood vessel's gotten small. That's called vasoconstriction, decreased blood flow. And so that's what we see the blood vessels do when the body gets too cold. And if you're getting vasoconstriction, we're getting less blood flowing through these blood vessels in our skin. That's because we're forcing that blood to go to our vital organs. So we're shunting it away from our skin. So we squeeze the blood vessels, make them small, and force that blood to the larger blood vessels that are supplying your internal organs. Right, so just be familiar with those two terms. Right? This is vasodilation. The diameter of the lumen of the blood vessel, which is that space where the blood goes, gets bigger. Vasoconstriction, the lumen shrinks down, it gets smaller. The diameter gets smaller. Less blood flows through this, more blood flows through that. Just to kind of give you an introduction to some concepts that you're going to see in this course and in 211. So I just wanted to throw it out there and introduce you to it. All right, then we have sensory reception. Remember I said you have a ton of nervous tissue in your skin. So most of our nervous tissue is going to be in the dermis there. And so they are sensory related. So then things that you can sense like heat, cold, touch, pressure, vibration, pain, you will see specific sensory receptors in your skin designed, right, to monitor those stimuli. And so we'll initiate some sort of response. So if your thermoreceptors determine that it's too cold in this room, the eventual outcome by your effectors is going to be shivering, vasoconstriction, okay, goosebumps. So that's what we'll see. All right, questions about any of that? We're going to go in through this course and talk about some of these concepts in a little bit more detail. All right. So just to review, we saw this in lab. You have two layers to your skin. There's a third one that's listed up there, but it's not part of the integument. The outer layer is epidermis, made up of epithelial tissue, specifically stratified squamous epithelium. And if you really want to get specific, what type of stratified squamous epithelium? Begins with a K. Keratinized. Yep, keratinized. And what does keratin do? Kills, but when it kills the cell, what's it do for the cell? Makes it stronger. Okay, it makes the cell stronger. All right, then we have the deeper layer, which is the dermis. And this is made up of two sublayers, and we'll talk about that again. But a lot of connective tissue there, but keep in mind, the main type of connective tissue is dense irregular connective tissue. You have areolar connective tissue in there too, but dense irregular is way more. And then finally, we have the subcutaneous or the hypodermis, which is not part of the integument. And so this is that layer, mainly a fatty layer. It's mainly made up of loose connective tissue. And the two types of loose connective tissue, oh yeah, it's listed up there, all right, are going to be adipose, the fatty tissue, and then our areolar, our other loose connective tissue there. So this layer will lay right on top of like skeletal muscle. And I think I was telling you that when you start to dissect, you're dissecting a cadaver, you peel back the skin, then you'll peel back the hypodermis, that fatty layer. Then you should see right underneath, depending on where you're dissecting, usually skeletal muscle. All right, so keep that in mind. I can't say it enough that the subcutaneous layer is not part of the integumentary. But we just don't have another chapter that we're going to talk about it in, so why not here? All right. Moving on. All right, we saw this picture just to kind of give you an idea of all the things that we see inside of your skin here. I mean, the epidermis is pretty much just epithelial tissue, and then you have the variety layer deep to that. That's the dermis that's going to have all the other types of tissues in there, okay? All right, so quick review. Won't spend too much time on this because we talked about it on Monday. So starting off with the epidermis, it is made up of not primarily keratinized stratified squamous epithelium. And depending on where we are, if we're in thin skin or if we're in thick skin, we can either have 4 sublayers or what we call strata or 5. If we're in thick skin, we have 5. And if we're in thin skin, we have 4. Oh, it's up there. Or we have 4. And I was going to ask you which layer is only in thick, but it's up there. All right. And so the one layer that you see in thick skin is going to be the stratum lucidum. It's a relatively thin layer. It can be anywhere between 2 to 3 cell layers thick. All right. So we're going to move through, again, a lot of those slides that you saw on Monday. We're going to quickly kind of review this. So you kind of sit back and enjoy. I'll talk about some of this stuff in a little bit more detail. Keep in mind, in this layer here, it is 1 cell layer thick. We also refer to this layer, and I've been known to ask this on tests, stratum germinativum. And so these cells here are constantly dividing. Remember what I told you. You'll have in cells that are constantly dividing, you start off with 1 cell. And what's the process of division? What do we call it? Begins with an M. Mitosis. Yes. Not meiosis. Meiosis only involves oocytes and sperm. Okay? Eggs and sperm. Everything else undergoes mitosis that's capable of it. So you start off with the dividing cell, and then you'll have 2 cells at the end, which will be identical to one another. And those are called daughter cells. So what happens here in this layer here is that when these cells divide, 1 cell stays, the other cell moves into the next layer. So the 3 cell types that we're going to see in this layer are the keratinocytes, our melanocytes, and then our Merkel cells or tactile cells there. So the predominant one, where we spend most of our time talking about, are going to be the keratinocytes. And then I'll go through this and discuss the different ones here. Right? So melanocytes, and that's the cell that makes the melanin, and its job is to protect our DNA. And then our tactile cells, known as the Merkel cells, these are going to be our touch cells here. So literally, when these cells experience pressure, that pressure is going to change the shape. We call it deform the shape. I hate to use the word deform because then people think associate with damage, but it's just going to change the shape of the plasma membrane of these cells. And that process causes those cells to release a neurotransmitter, which will stimulate the sensory neuron there. Okay, so let's go into detail here. So our keratinocytes, the most abundant cell. And so these are the ones that when they're constantly dividing, 1 stays and 1 goes, but ultimately it's going to make this protein, and that protein is going to make the epidermis stronger. And it won't start doing that until we get into the stratum granulosum, the 3rd layer. That's when they start the process of keratinization. So for this cell here, just keep in mind, its job in the stratum basal, that first layer, is to divide. 1 stays, 1 goes. Because it's got to do one more thing before it starts producing keratin. What do you think that thing is that it's going to do in the next layer? It's got to make friends, right? It's got to make bonds. It's got to start to create these tight junctions and these hemidesmosomes. Excuse me, I can't talk tonight. Right? It's going to start to make itself, because remember that those cells are tightly packed, but they can slide around because they've just divided. So we don't want them sliding around in these layers. We want them to start to form these adhesions with their neighboring cells so they're stuck in place and so things aren't shifting around. So that's what we're going to see as the keratinocyte migrates through the layers there. All right, the melanocytes, these will be spread out, okay? throughout the stratum basale, and their job is to produce that melanin. That's what gives our skin its color content there. And the stimulus for that is UV, ultraviolet radiation. And so these cells are the sharing carrying cells. They make the melanin and they share the melanin with the neighboring cells because keratinocytes can't make melanin. So they need some help to protect their DNA, even though they're not going to have their nucleus for much longer, right? But they need to be able to protect themselves. So these melanocytes, right, through the organelles are called melanosomes, and that makes the melanin. And then it'll store and share that pigment with the neighboring cells so they can protect themselves. So keep in mind when we're talking about the purpose of melanin, it's to shield. Okay, protects that, makes that protective coating around the nucleus so that ultraviolet radiation cannot go in there and just start splicing your DNA, that dimerization process. All right, tactile cells. This is the last cell type that you're going to see in the skin. Right? These are also known as the Merkel cells, and this is the one I was telling you about, that when you compress the plasma membrane, it's going to release the neurotransmitter, which will then stimulate the sensory receptor with the sensation of what we call touch. So they're not terribly exciting, but not bad. Okay, so that's the stratum basale, the very first layer. So let's migrate up to our next layer, which is called the stratum spinosum. And so here, this is where all the freshly brand new keratinocytes have just moved into. And so they start to form those adhesions with their neighboring cells, right? Before they start to produce the keratin, they got to make those tight junction relations with each other. So they're tightly packed in there. Also, what we're going to see are our immune cells, all right, of this class called Langerhans cells or the epidermal dendritic cells. So I talked about these cells with you. So these are the ones that are going to monitor for unhealthy cells. Okay, these are the ones that are primarily effective against the early signs of cancerous cells. I was telling you that these Langerhans cells can identify cancerous cells early on in the process before it becomes an actual sizable, noticeable tumor, which is, and I can guarantee you that everybody in this room at one point has had a cancerous cell in their skin, right? That these cells have taken care of, which is good, which is really good. How do they do it? Through this process. What is that? It's phagocytosis. Pardon? Yep, cell eating. Okay, that's the Pac-Man cell. So you need to know that term because phagocytosis is cell eating. Does anyone remember what the process for cell drinking? That's the nickname for it. Penocytosis. Yep. Penocytosis is cell drinking. So mainly when we undergo phagocytosis, it's going to be usually a larger structure, a larger molecule, like Pac-Man, all right, gobbling up the power pellets or whatever, chewing on that. Penocytosis is usually when we're dealing with something more of a liquidy form, like lipid droplets, things of that nature. If you're not sure, review that concept in chapter 4. You're going to see some questions on those processes of exocytosis, which is there's exocytosis, cell-mediated exocytosis, and then phagocytosis. I'm going to review that. Okay, wait, did I hit everything on there? Yep. Okay, the third layer is the stratum granulosum layer. Again, not a very thick layer, 3 to 5 cell layers thick, but this is where keratinization begins, where the cells start the process of their death march. So, I mean, really nothing else exciting that goes on in this layer. So the cells will start to fill up with keratin. That process starts to kill off the organelles, and eventually the nucleus, and then the cell's considered to be officially dead. All right. So that's stratum granulosum. So this next layer is the layer that we don't see in all of your skin. This is the one that's only found, right, in thick skin. This is the stratum lucidum. Right, so we all know where that is. And the other thing about it is it has this intermediate product here for that keratinization process called eledin. You know, I always kind of found this to be interesting, this statement here. Layer helps protect the skin from ultraviolet light. I get the hands, but the feet, how often do they see the sun? You know, I mean, I've always wondered that. But anyways, it's helpful. Okay, so that's stratum lucidum. Last one here is going to be the stratum corneum, your outermost layer. It is going to be found in all areas, wherever your skin is. This is where you're going to find the stratum corneum. This is going to be the one that can be 20 to 30 layers. It could be more, but they're all dead. All these cells have since died because of the keratinization process. So when you're looking at a slide of this layer here, you should not see any nuclei. You should not. It's taken these cells quite some time to get there, about 2 weeks to get into this layer. Depending on how thick and how far they have to migrate and move, they could spend another 2 weeks in that area there. So this is where after the cells here, these keratinocytes get into this layer, ultimately, without the help of sebaceous glands or any of the sweat glands there, these cells will have that arid kind of dry, right, environment. And I told you all this in lab. This is good for immune function. Bad if you're trying to moisturize, all right? But that type of environment is hostile to certain pathogens. This is where I was talking to you about how you have that normal flora of certain bacteria that lives naturally on your skin, and it kind of keeps your fungus, right, flora at a certain level. For example, this is the one I was telling you about where people are on antibiotics, they're more prone to fungal infections. Well, this environment here helps to keep in check your bacteria levels, because if you get an overpopulation of bacteria, then you're more prone and more likely to get some sort of bacterial infection. Nobody wants to deal with that. All right, so here you can see, here's a nice thick layer of stratum corneum. Right up through here, you can see a nice sweat gland duct moving through. And so all this picture over here is showing you the 3 different types of cells found in the stratum basale. There's your Merkel or tactile cell, there's a melanocyte, and then you can see the keratinocytes of the remaining cells. And there's our Langerhans or our dermal or epidermal dendritic cell, with all the layers there. All right, real quick, let me run through this. Variations in the epidermis, thickness, color, and skin markings. Right? Fast, easy to remember. Thick skin, you have all 5 strata of the epidermis. Thin skin, you only have 4. Thick skin, you have sweat glands, but you don't have hair follicles because you don't have hair, right? No hair on your palms, no hair on your soles. So if we don't have follicles, we don't have hair follicles, then we don't need sebaceous glands. That's that gland that we saw hanging off of the hair follicle, is that multilobulated gland. You don't believe me? There it is. There's your sebaceous gland. And you can see it's associated here with that hair follicle. So no hair follicle, no sebaceous gland. Easy peasy. Right? But we still will have sweat glands. So when we get into thin skin, we only have 4 strata. We don't have the stratum lucidum. This is going to be in the majority of the areas in your body. You have sweat glands there. Hair follicles. If you have hair follicles, then you're going to have your sebaceous glands. So that's thin skin. So we saw this slide in lab. Look at the size of that stratum corneum. Here's our thick skin. Here's our thin skin there. All right, skin color. These three things can influence our skin color. Hemoglobin, which is that protein molecule that binds respiratory gases, right, in our red blood cells. So the more oxygen you have attached to hemoglobin, the more red in appearance your blood will be. Less oxygen, it will appear less red, like a dark red, okay? So depending on how much oxygen is on the hemoglobin will determine how red your red blood cells are. So obviously then, where there's more blood flow, you'll have more of a red hue to that area, as evidenced when you've seen someone that's very flushed, they've been exercising or in a very hot environment. All right, melanin, UV, ultraviolet radiation protection, because the melanocytes make the melanin that coats your nucleus, and that is going to give you, right, that coloration. Now, do you need to know these different ones? All right, like the eumelanin and then our pheomelanin? No, it's just something that I just threw in there, okay, that you can see what gives us, right, certain colors to our skin there. But you definitely want to know this. Albinos, folks that are afflicted with albinoism, it's not that their melanocytes have reduced the amount of melanin that they're producing. They just quit. They stopped producing melanin, or they were never able to produce melanin. So those individuals appear almost paper white, right? And so this is a genetic condition. And for those of you that have taken genetics, it is a recessive genetic condition, which means you have to get that gene from both mommy and daddy. All right, keratin. This is that one I was telling you about with the Oompa Loompas. This is going to give you an orange coloration. Right? Certain vegetables will have high amounts of keratin there. The wonderful thing about keratin is its role in reducing free radicals. You'll also need it, and we'll talk a little bit about it because keratin is affiliated with vitamin A, right? Because it gets converted into vitamin A. When we get into chapter 16, we talk about vision, but it plays a large role as an antioxidant, which is it helps to reduce free radicals. That was the analogy that I gave you with that little kid swinging the yo-yo around in the china shop or the antique shop. That's what this molecule does. It helps to decrease that. This is pretty much, I'm going to skip this because I already talked about that. All right, and then we have our other skin markings here. Did I already? Yeah, okay. Our skin markings here, right? Hemangioma. And I didn't want to go into too much detail in the lab because I knew I was going to talk about it here. One, you have to understand it is a benign blood vessel tumor. And some of you may have seen children born with hemangioma. Quite commonly, it's usually on the head or face. And so most of them are going to be benign, meaning in some situations, if you just leave it alone, it can go away. In some situations, you might have to have surgical excision, and then you have to keep an eye on it in other situations because it could then transition into a more serious, I don't want to say cancer, I hate using that word when I'm describing this, into a more serious tissue modification there. Right, so when we're talking about capillary hemangiomas, these are the ones that you'll see pretty much on young babies. It'll look like a small strawberry kind of colored discoloration in the skin. And so most of them will disappear as that individual gets older. In some cases, we'll have cavernous hemangiomas. This will involve larger blood vessels. This is the one that sticks around for a long time. And so if you've taken a pathology course, they usually describe it as port wine stains. Port wine is a darker red wine. So if you've ever seen it spilled, right, it looks like literally somebody spilt port wine on that individual and it just stained the skin in that area there. But that's a permanent thing. That won't go away. Right. And so that's for the cavernous hemangioma. All right. Ridge patterns, again, discussing are fingerprints essentially. Your epidermis and your dermis, when they interact with each other, that area of interaction creates these mild, slight ridges. If you look on your fingers and even on your feet, you'll have these finger or toe prints there, and they're designed to create friction. So it's easier to grasp things. But these fingerprints are going to be unique to that individual. Okay, so that's why we use it in some situations for personal identification. I like fingerprints because they help increase my friction so I can grasp things easier. All right, but that's their purpose here, and you can see the pictures there. Okay, so they're just depressions, peaks and valleys, depressions and elevations, and that's due to where your epidermis and your dermis come in contact with one another. So our first clinical view of the day, when we talk about radiation, sunscreens, and sunless tanners here, right? So I mentioned this before, okay? Sun produces these 3 different types of ultraviolet radiation. We don't have to worry about C because it doesn't make it to Earth. So who cares about that? But UVA and UVB are the ones that do make it to Earth. And so they're both not good, but remember what I said, B is the worst one out of the 2 there, right? And so these are going to be the ultraviolet radiation that we speak of that's going to stimulate your melanocytes to produce more melanin, okay? They're producing melanin. I don't want you to think that they don't produce melanin at all as evidence, because we all have a certain color to our skin, right? But in this situation, our ultraviolet radiation will stimulate more production there. And so, of course, it's really been pushed or advocated for or suggested, especially in the dermatology realm, that everybody, no matter what skin tone you have, should be wearing sunscreen. When I was growing up as a kid, now granted, I grew up in New York, and so the sun is not as intense up there as it is down here. My mom never put sunblock on me, and I was outside all the time, you know, running around. So I have no idea what my future holds for me when I go and see my dermatologist, you know, if I will have skin cancer in the future. But now, and I even when I saw my dermatologist, I asked them, and they recommend that everybody put on sunscreen no matter what. Because I never put it on. I go mow the lawn. And I was like, I'm not putting that on. She goes, no, you wouldn't put that on. Right? I'm only out there for about 45 minutes. All right. And then we got our sunless tanner. Right. And so again, this is that stuff that I was telling you about, that guy that I worked with, the Oompa Loompa guy, that was using. Right. And so a lot of these sunless tanners now will have that keratin in it because your body can process that, right, as it's breaking it down, and it doesn't really have any harmful metabolites. And so these sunless tanners will give the appearance of tan skin, right, without exposure to the ultraviolet radiation. I think this was years ago, not the CDC, it was the FDA. They actually had classified tanning booths. They said that tanning booths are the equivalent of ingesting, it was either arsenic or cyanide. I couldn't remember which. And I'm like, well, both of those are bad, you know? But that's what they were saying, chronic exposure in tanning booths. So take it for what it's worth. Okay, so the next layer, the second layer to our skin, is the dermis. This is the deeper layer. This is the thicker layer, but there's only 2 sublayers in our dermis. This is where we're going to find all the stuff here. Right? So if you look here, when we talk about this, we'll move through this relatively quickly. All these structures here, blood vessels, sweat glands, sebaceous gland, hair follicles, nail roots, sensory nerve endings, and erector pili. All of those tissues are going to be found in the dermis. And so our 2 layers, the papillary layer, which is the more superficial layer, it's the thinner layer, right? And then we have the reticular layer, which is going to be the deeper layer, and that's going to be the thicker layer. That's where you're going to find most of these structures that I just mentioned predominantly will be found in the reticular layer there. All right, so the papillary layer is made up of a lot of loose connective tissue, the areolar connective tissue. And so this is the layer that I was telling you about that had all the bumps in it. And so you'll have blood vessels that'll go up in there into those little bumps. You'll have nerve endings that go up there. A lot of nerves down, not a lot of nerves and blood vessels that run in through that area. Because remember, your epidermis is made up of epithelial tissue. One of the characteristics of epithelial tissue is it's avascular. So your epithelial tissue in the epidermis does not have its own blood supply. So if you, without a blood supply, whatever tissue that we're talking about does not stand a chance. Okay, unless you're certain types of tissue like mature cartilage, then it has a different way of getting nutrients and getting rid of wastes. Same thing here with our epithelial cells. We have to figure out a way to get them their nutrients and also get rid of their wastes. And we're going to use that process of diffusion. But we got to get our blood vessels as close to those cells as possible. And the papillary layer allows us to do that. Right. Then the deeper layer is the reticular layer, and that's the one that is made up of the dense irregular connective tissue. And because it is thicker in a larger layer, it'll have more dense irregular connective tissue. That's why dense irregular connective tissue is the primary connective tissue type in your skin. And one of the characteristics about dense irregular connective tissue is that it can withstand multi-directional stresses. So if you pull on it in a bunch of different directions, it can withstand that. Right? It can be highly vascularized because there's more ground substance and more space to have blood vessels in there. And so that's what we'll see here in our reticular layer. So this is just demonstrating to you the interaction between the papillary layer here and then the epidermal layer. And so if you kind of zoom in, I love this picture here. These two pictures off to the right. Those are electron microscopes. So you can see, right, that's what the papillary layer looks like. And so you can see you have these elevations, and that's what this is showing you. And then there's also depressions, and that's what those darker areas are. So this and these epidermal ridges here, that's what gives you your fingerprints. And then when we go down here to the reticular layer, you will see you have more of like these swirls here. And that's mainly because of, you want to take a guess? It's not up there. Well, what's one of the components of connective tissue? Remember there's three parts to connective tissue? Cells. I don't want to give you the other ones because it'll give away the answer. Yep, protein, fibers, and ground substance. So what do you think out of those three things this stuff is? Fibers, protein fibers. What do you think specifically? Not well, there's elastic in there. I shouldn't be. Yeah, there's elastic in there. So you'll see elastic and collagen. Yep. But that's just a great example here. You can just see how it's more swirled. Whoops. Okay. Okay. So this is what and I'll move through this relatively fast. Right when we're talking about the lines of cleavage. Not too many people usually care about the lines of cleavage, but more people actually are more interested in stretch marks. I got stretch marks, you know. So basically on this previous picture here, when we're talking about looking at these tissues here, you have these collagen fibers and there's some elastic tissue. So when we talk about, these tissues here, you'll have these bundles of collagen fibers and elastic fibers that are going to have a certain orientation. Some will go horizontal, some will go vertical, then some will go at odd angles or oblique angles there. And so what these fibers are showing us, all right, they're going to create what we call the lines of cleavage. The lines of cleavage. And this essentially allows us to know where the tension is, but it's really helpful for our plastic surgeons when they need to make an incision if they want to minimize scar tissue formation. So if they know the orientation, if they make an incision that's parallel to the orientation, like in this next slide, If you make an incision that's parallel to the orientation of those collagen and elastic fibers, you get a smaller wound and a smaller scar. If you go perpendicular to those lines of cleavage there, to those collagen fibers and to the elastic fibers, you're going to get a larger wound and thus a larger scar. So that's what this picture is showing you, right? The different presentation for, all right, those collagen and those elastic fibers there. So some of us may have experienced, some of us may have experienced stretch marks. And so what causes that to occur is when these collagen and elastic fibers are tensioned past their point of their ability to withstand that stretch and tension. So what will happen is we exceed the capabilities of those tissues there, and we'll start to damage those protein fibers and tear those protein fibers. And so it will leave these stria, which are stretch marks. And you'll see those in people that have had Cushing's disease, and some women that have gotten pregnant. You can see it after they've given birth. Weightlifters, for example, if they undergo significant muscle hypertrophy, right, you can see where their muscles have grown and the skin wasn't able to keep up with it. They'll have stretch marks around their axilla, their armpits and whatnot. So that's essentially what happens with these stretch marks, is that area of the skin had just been stretched beyond its capabilities and it tore. I mean, the skin hasn't torn, collagen fibers and the elastic fibers. All right, so when we're looking at our dermis, remember our dermis is not epithelium, so it's going to have its own blood supply. Epithelium is avascular. So when we talk about innervation, you should be thinking what? Is it up there? Well, the word is in the word innervation. Think of nerves, okay? So innervation has to do with nerves. Obviously, blood supply or vascularity has to do with blood. So you want to know the difference between those two terms. So when we're dealing here with our integument, specifically the dermis, that's the layer that has all of those different tissues in there. And so one of those tissues was nervous tissue. So we're going to see lots of sensory nerve fibers. Sensory nerve fibers are going to take stimuli information, whether it's inside or outside the body, and it's going to transmit that information from the receptor to your central nervous system, pretty much to your brain and spinal cord. So keep that in mind. Sensory is incoming input information into your central nervous system. So all those receptors that are in your skin for pain, for temperature, for touch, vibration, all of that stuff. Right? That's sensory information that's monitoring what's going on in this room, but also what could be happening inside my skin, okay? So that input information goes to the central nervous system, and then we have what's known as our motor nerve fibers. Now, I haven't gotten into the kind of concept of how the nervous system operates briefly in chapter 1. Remember homeostasis, right? The homeostatic control mechanism. Stimulus, receptor, control center, effector. So the sensory aspect is receptor to the control center, that information that's flowing, that's that sensory input information. Then the control center takes that information, it processes it, and then it is going to determine what it's going to do as a result of the stimulus. And in order to do that, it's going to send what we call motor output information to the effectors. What two things are effectors? Nailed it. Muscles and glands, okay? So that's what these motor nerve fibers are going to do. They're going to carry the marching orders from your central nervous system, from the brain and spinal cord, to a muscle or a gland. And that's what happens here. So guess what? It's going to control blood flow and, well, gland secretions. Gland is an effector, right? We agree? What do you think blood flow? What's the effector for blood flow? It's either a muscle or a gland. So Do you think glands affect blood flow? Right, so it must be muscle. Specifically, which of the 3 muscle types do you think it is? I'll give you a hint. It's not cardiac, because that's only in the heart. You think it's skeletal or smooth? Smooth. Yeah. Skeletal is voluntary. We can control that. Can't control the diameter of your blood vessels. We can't consciously control that. Smooth muscle is involuntary. Okay. So that's where we get the muscle from for blood flow, right? Because it's going to affect the diameter of those blood vessels through vasoconstriction and vasodilation. So that's what we're going to see there. That was a long way to explain that. All right, so here, when we're dealing with our dermal blood vessels, we're going to see how a lot of the blood vessels are going to be pretty small, all right, in our dermis there and the dermal papillae there. And our larger vessels are going to be deeper in the reticular and in the subcutaneous. So think smaller vessels more towards the surface of the dermis, larger blood vessels more towards the bottom there. And it plays a role because remember, epidermis does not have its own blood supply. So in order to get our nutrients to the epidermis, we need to have a nice supply in that papillary layer there. All right, so this slide here is just going into a little bit more detail. I'm hoping that when you go through and you look at that, you should be like, oh yeah, Dr. Kaz already talked about that. I feel pretty good about what vasoconstriction is. All right, so the actual definition of vasoconstriction, blood vessel diameter has narrowed. So we went from here to here, got really small. Decreases blood flow. Right, and so if we can't get blood into that area, we'll just send it. Oh, you don't want our blood? All right, we'll send that blood somewhere else. We'll send it to the vital organs, to our core, right? And we do that to conserve heat. Why? Because we've been out in the cold. So if we're shunting blood away from our skin, we're not going to have that nice rosy red coloration. We're going to have more of a pale coloration there. It's vasoconstriction. So the next one is going to be vasodilation. So now we're going to swing it over here. We get the lumen nice and big. Vasodilation is when we actually increase the diameter. And when this happens in the blood vessels close to the surface of our skin, it's going to allow us to get rid of heat. So we can get rid of that heat. Sweating through evaporation helps that process more effectively. So what we're trying to do is lose heat, thereby cooling us off. And that's in response to exercise. You're out, living in South Carolina in the month of July, all right? Okay, so I hope you have a pretty decent understanding of dilation, or excuse me, of vasodilation and vasoconstriction. If not, just review that material there. Okay, I want to talk about the subcutaneous and then we'll wrap it up. Not much to say about the subcutaneous. The first bullet point up there tells you it's not in part of the integument. I don't know how many times I've told you. I hope you're getting tired of me saying it because that means you know it, all right? And then you won't forget it, all right? So, not part of the integument, deep to the dermis, made up of 2 connective tissue types. They're both loose, and they begin with A, okay? Areolar and adipose. Good. So, because of adipose is a site for energy storage, right? Fats, okay? And then, because of that, we get cushioning, which helps with protection and insulation. And now, obviously, males put adipose tissue in different places than females do. Right? So depending on where your adipose tissue is going to be distributed is going to be determined whether or not you're XX or XY. That's just essentially how it is. But the nice thing about, let me see if I got a picture here. I'll come back to this, I promise. Oh, we're almost done. Oh, I gotta go all the way back. Oh, no, wait, hold on. Look down here at the bottom of your screen. That's the subcutaneous layer. Look, there's a lot of fat there, but what's close to the subcutaneous layer? Blood vessels. Blood vessels. All right, so subcutaneous layer is going to have a decent amount of blood vessels nearby. Right? But the beautiful thing about this is, right, when you give somebody an injection into that site, one, you can allow for a slow release, but you can get it into, all right, that area where the blood vessels are, so it can be absorbed rapidly into that tissue. All right. So that's why the subcutaneous area is a nice place to actually do an injection. All right, so this picture here, right, table 6.1 shows you these 3 layers here. And what I would say is, if you're pretty good with all the information on that table, you'll do all right. You'll do all right. So to kind of test yourself, take a peek, go over that material, and then go into more detail through your notes. Perfect. This is a great place to stop, because if you're not asleep now, you'll definitely be asleep after I start talking about this stuff. Right? It's not very interesting to talk about